So in this presentation, I will be talking about the management of weak cough in patients with neuromuscular disease, and this should hopefully bring together some of the themes of the previous webinars that have been posted on Education by Briaz. To understand what a weak cough is, we need to know what a normal cough involves. Firstly, this involves a deep breath in of up to 80% of the total lung capacity. The glottis subsequently closes for 0.3 of a second, and this allows a build-up of the intra-abdominal and intrathoracic pressure. Upon an abdominal contraction of more than 60 centimetres of water, there is opening of the glottis and a rapid expiratory flow greater than 360 litres per minute for anyone over the age of 12, and there are also reference values in children. When we talk about cough peak flow values, it's accepted that an assisted cough peak flow value of greater than 160 litres per minute is sufficient to eliminate airway debris and clear secretions. When it drops below that level, the person is at risk of secretion incontinence. We also know that when the cough peak flow sits between 270 and 300 litres per minute, that person is at risk of dropping to the critical value of 160 litres per minute. And this is because something as simple as a common cold can have effects on the respiratory muscle strength, and that can last for up to 21 days. When it comes down to what the guidelines say, they all state that a cough peak flow of less than 270 litres per minute, a cough augmentation technique should be commenced, and they don't specify what cough augmentation it should be, except in spinal muscular atrophy, where they state that mechanical insufflation-exsufflation should be used. To help us clarify what cough augmentation technique should be used, a group of experts looked at the evidence-based and determined the technique which should be used optimally depending on the person's forced vital capacity as a percent predicted, their forced vital capacity in litres as an absolute value, or their cough peak flow. You can see here that for different techniques there may be a large range. If someone's values for any of the cough peak flow, forced vital capacity or forced vital capacity as a percent predicted are in the green level, no assistance with regards to their cough is required. However, if they sit in this amber area, we need to consider techniques, and we can look at assisted insufflation with a manually assisted cough, assisted insufflation alone, and manually assisted cough or self-insufflation via glossopharyngeal breathing. When the values hit this red level, this is the critical level where they're at risk of secretion incontinence and have a severely weak cough. And for those patients, mechanical insufflation-exsufflation is the treatment of choice. However, I just want to point out that there are limitations about providing mechanical insufflation-exsufflation devices in individuals who are stronger. Indeed, this study showed that patients where the insufflation technique and the manually assisted cough exceeded 5 litres per second, there was no further benefit in using mechanical insufflation-exsufflation and a manually assisted cough. Therefore, those patients that are stronger benefit far more from a deep breath in and a manually assisted cough. And you can see here, these are their cough peak flow values for MIE alone, IPPB, delivering the insufflation and a manually assisted cough, and MIE and a manually assisted cough. And this is their insufflation capacity with no benefit from using MIE. And actually on their peak cough flow, the greatest change in this stronger group of patients was with IPPB and a manually assisted cough. And this is because in the stronger group, the manually assisted cough and the mechanical insufflation-exsufflation transiently exceeded the vacuum capacity of the MIE device. So I've highlighted that treatment seems to be dependent on cough peak flows. However, cough is far more complex than just a number. What does the patient say? We need to ask them whether their cough is effective. Is it effective when they're well or when they're unwell? When they cough spontaneously, is that stronger than when I ask them to cough? I think we all know patients who will say that their cough is weak, but actually don't regularly use cough augmentation techniques, and vice versa, others that will look at and say your cough is strong, but they struggle to clear their secretions. We want to know whether they can clear their secretions into their mouth or whether they get stuck, and can they clear better in certain positions depending on what their posture is. When it comes down to doing a formal assessment, what we want to do is we want to look at the rise and fall of the abdomen. We want to listen to the expulsive component. Can we hear that rapid, that opening of the glottis with a high expiratory flow? If they can't, we can ask them to phonate E, 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 E. And what we're looking at there is whether that is clear and whether the cords are opening and closing effectively. We want to observe the abdominal contraction and listen to how strong the cough sounds. Do we hear secretions moving? And we can measure it, and that can be simply done with preferably a paediatric peak flow meter if we don't have a formal pneumotachograph, as this will give a more accurate reading as the scale is more directed at lower flows. So my take-home message for the first part of this presentation is we shouldn't use cough peak flow alone to initiate airway clearance techniques. We want to look at the patient as a whole because it's not simply down to a value. Consider the number of respiratory tract infections and the severity of them. Bear in mind that a reflexive cough could be more stronger than a volitional cough. Look at the audibility and whether secretions are cleared into the mouth, and determine, most importantly, the correct technique for that patient. As respiratory physiotherapists, we manage patients as a whole, and we've got a whole host of techniques that we can use with them. I just want to have a little look at the consequence of neuromuscular disease. So our patient with neuromuscular disease potentially has respiratory muscle weakness, which leads to decreased tidal volumes, a decrease in our chest wall range of movement, and an ineffective cough. And that can in track lead back to decreased tidal volumes. We've got some patients that have cough desensitization and let secretions sit there, and that can again feed back into recurrent respiratory tract infections. And there are some individuals that will have silent aspiration, and this can feed into chronic suppurative lung disease, respiratory tract infections, and further, due to the respiratory muscle weakness that is further pronounced when people are unwell with neuromuscular disorders, a further ineffective cough. I want to talk a little bit more about the consequence of a decreased chest wall range of motion. One such measurement that helps evaluate chest wall stiffness and changes in this is the respiratory system compliance. What respiratory systems compliance does is look at the expandability of the lungs and the chest wall. You have dynamic compliance, which is a combination of lung compliance and airway resistance, defined by the changes in lung volume, by the change in pressure, in the presence of flow, and is measured during breathing. We also have static compliance, which is a change in lung volume by the change in pressure in the absence of flow, and describes pulmonary compliance where there is no airflow. For example, the measurement is taken in an inspiratory pause. And lung compliance can be calculated by dividing the volume by the pressure, as shown in the equation here. In this narrative review by Nicole Shears and co-workers, they highlighted studies that have used respiratory system compliance as an outcome measure in patients with neuromuscular disease. I recommend that if you're interested in this area that you read this review fully because it's a great resource. But in general, older patients with progressive neuromuscular disorders, the respiratory system compliance and the chest wall compliance was lower than the adult non-affected population. Ways that we might affect respiratory system compliance are single breath insufflations, basically having a single deeper breath via a ventilator, resuscitation bag or intermittent pressure, positive pressure breathing device. The patient breathes away and then there is an augmented deep breath in. You can also use stacked breaths. This is where multiple breaths are delivered via either mouthpiece ventilation, a resuscitation bag, or a lung volume recruitment kit. They're delivered to the patient as shown in the diagram here. So we can see a breath is given in, there is an inspiratory pause, breath in, pause, breath in, pause, and that is as many breaths as is needed in order to reach total lung capacity. The patient then breathes out. Let's just take a moment to look at this in practice here. So you can see that the breath is delivered in, giving the chest wall a stretch, and then there is passive expiration. This technique is shown to be helpful in patients with multiple sclerosis. What's interesting in this group of patients was that they had a group of multiple sclerosis patients who improved with the technique and a group that didn't. In those that responded, they had a lower rate of decline of their peak cough flow and of their vital capacity compared to those that did not respond. So here you can see in litres their forced vital capacity and those that had the mechanical insufflation exhalation rate of decline and the peak cough flow. What they didn't say is whether they had a group of patients that didn't respond that had a significant bulbar insufficiency. Until Nicole Shear's narrative review, there was no set description of what lung volume therapy sessions looked like. She quantified this as 4 stacked breaths followed by an exhalation and repeated 5 times, which you can see the example here. So we have a breath in, hold, breath in, hold, breath in, hold, breath in, and a passive expiration delivered for the set amount of repetitions for a set. And that the patient does 5 sets in total. Studies shown in grey were looking at a single lung volume recruitment session with a resuscitation bag. And when looking at a single session of assisted insufflation, there were mixed results. Studies in grey are looking at lung volume recruitment with a resuscitation bag or kit, looking at repeated assisted insufflation. And I'd like to spend a couple of minutes talking about the last 2 studies that I've highlighted here in red. In the study by Sherry Katz, in a population of Duchenne muscular dystrophy individuals with a forced vital capacity of 85% predicted, there was no difference between the lung volume recruitment group and the control group over a 2-year period. And this was for the values of the maximum insufflation capacity minus the vital capacity, peak cough flow, assisted and unassisted, maximum inspiratory pressure and expiratory pressure at the mouth, and the total lung capacity. Nicole Shears looked at a group of adult patients with neuromuscular disorders and found that there was no difference in the primary outcome of respiratory tract infections over a 3-month period with lung volume recruitment. However, there was improvements in the maximum insufflation capacity and vital capacity, potentially indicating that this technique needs to be learnt. Her group of patients were different to that of Sherry Katz's in that their vital capacity was around 40 to 45% predicted. And one of the things that Nicole didn't ask her group of patients was whether, when they had a respiratory tract infection, whether this technique actually helped them. So my take-home message with regards to lung volume recruitment is that the data suggests that lung volume recruitment may be needed to be commenced in a specific and unyet known window in neuromuscular patients for a prophylactic effect. The longer-term clinical impact of increasing maximum insufflation capacity still remains to be determined, and further objective lung volume recruitment use and clinical meaningful outcome measures are needed. So let's now have a look at the consequence of an ineffective cough. As I highlighted at the start of the presentation, we have lots of tools in our toolbox as respiratory physiotherapists to manage patients. And the primary method of airway clearance in an ineffective cough is a proximal airway clearance technique, and I've highlighted them here. Just looking at them in a little bit more detail, we can assist the expiratory phase with an abdominal assisted cough. And we know that the Heimlich type or the thoraco-abdominal assisted cough increases expiratory flow greatest because you have an effect on both the thorax and the abdomen, increasing the expiratory flow. We've talked a little bit already about the inspiratory phase and the fact that we can use breath stacking to stretch the chest wall, but we can also use it to increase our inspiratory capacity and support the inspiratory phase of a cough. We know that a single insufflation increases cough peak flow and lung volumes, and the same for stacked insufflations. Now, it may be that we need to actually consider to get the best improvement in these techniques using or letting the patient do the breath stacking themselves. And here you can see with breath stacking with a volume cycled ventilator that the cough peak flow in individuals with neuromuscular disorders increases greater than breath stacking with someone else doing it for them. We tend to focus on lung volume recruitment for chest wall stretching or to enhance a cough. However, it should be noted that it can also help for up to a 30-minute period with throat clearing, helping patients to swallow after a cough, and improvements in a subglottic swallow maneuver. We all have patients who tell us that they don't clear well with a device or a technique, but actually 20 to 30 minutes later they bring up a large amount of secretions. So we need to not just evaluate treatment efficacy at one particular point in time, but it is important that we ask patients, are you able to clear at a later period, and if so, when that is? And the basic physiological method for this, and this was seen in some of the single studies, is that for a period after the treatment, that there is an enhance in our lung volumes, which will in turn help us to clear. We of course can combine our techniques, our inspiratory and expiratory techniques, or use mechanical insufflation-exsufflation devices. And in this fluoropots, you can see in groups of neuromuscular patients with ALS and without ALS, airway clearance or cough expiratory flow increases and favours the use of mechanical insufflation-exsufflation. You can set people up in various different ways, and it really depends on where you are as to what your practice would be. You can use symmetrical pressures as shown in this example, starting with an insufflation pressure of +20 to -20, insufflation time of 2 seconds, exsufflation time of 2 seconds, and increasing the pressure for a good rise and fall and to patient comfort. And in some instances, you may need to go up or above +40 to -40 centimetres of water. This tends to be used more in Southern European countries, South America, as well as North America. The northern part of Europe approach is to set a greater exsufflation pressure to be 5 to 10 centimetres of water more than the insufflation pressure. And this personalised approach is aiming to further enhance an expiratory airflow bias. And this is just 2 publications from Northern Europe showing in an ALS population, a Duchenne and SMA population, and higher expiratory pressure was used when titrating MIE, and also in this Nordic population. A suggested algorithm for this is shown here, and it walks you through how to do this, whether the patient is on a ventilator or whether they're not, with starting to titrate the insufflation pressure and then setting the exsufflation pressure to be 5 or 10 centimetres of water more, and some indications around timing if needed. And I'll let you look at that in further detail should you need to. But there are questions about which strategy is best, and Britt Hove and co-workers aim to answer that question in children with neurodisability. What they did was they looked at symmetrical pressures, which are shown in blue, asymmetrical pressures in this orange, and a personalised approach, which is in green. Let's take a moment to look. In symmetrical pressures, they used +50, -50. Asymmetrical pressures, depending on the age, +25 to -40. And in older children, +30 to -40. And the personalised approach was truly personalised. When we look at the effect of MIE on an assisted cough, the greatest change in flow was with the high symmetrical pressures. And this was for both the young and the older population. Interestingly, patients rated that strategy as more uncomfortable compared to a personalised or asymmetrical approach. But when it came down to efficacy of the treatment, there was no difference whichever strategy you used, as rated by the patients. In this more also recent study from Niraj Shah of the Lane Fox group, they looked at the effects of pressure on expiratory flows in a wide group of patients. They had individuals with Duchenne muscular dystrophy, those on long-term mechanical ventilation via a tracheostomy, and a spinal cord population. They defined low pressures as +30 to -30 and high pressures as +60 to -60. And that they found that in order to create the greatest expiratory flows, high pressures were needed in all of the groups apart from the Duchenne muscular dystrophy group. And that they showed that high pressures were not advantageous in that group. Now, that said, I don't think I can specifically remember in my clinical practice using +60 to -60 in a group of Duchenne patients. Now, this group of Duchenne patients was incredibly weak. You can see here that their sniff nasal inspiratory pressure was 11 centimetres of water compared to the other groups, and that their unassisted peak cough flow was 46 litres per minute. What they looked at was the flow volume curves for the low pressure and the high pressure, and this is an individual that shows no upper airway collapse. We've got the inspiratory and the expiratory flows, and you can see that they're open. Whereas in the individual that had upper airway collapse with the high pressure, you can see that there is a rapid decline in flow and it doesn't continue, and that there is better airway patency with the low pressures. And indeed, 6 out of 10 of their patients with Duchenne muscular dystrophy had upper airway collapse, 1 on insufflation and 5 on exsufflation, indicating that perhaps in severe weakness in this group of patients, that high exsufflation and insufflation pressures are likely to cause airway collapse. Now, this has been well documented in patients with ALS, and this very early study in 2004 looking at CT images of individuals with ALS showed that on exsufflation there was narrowing in a bulbar group. Tina Anderson has gone on to define this in her group of ALS patients and what's happening dependent on what area of the larynx is affected, and has come up with an algorithm that can help this. Now, subsequently, she has further stratified that algorithm in a recent paper where she looks at a suggested management of mechanical insufflation-exsufflation to get optimal upper airway patency in ALS patients. And what she has suggested is that the triggering is on to support the insufflation, that the pressures start at 10 to 15 centimetres of water, or the same as their non-invasive ventilation settings, that the rise time is adjusted depending on bulbar insufficiency, so it's high in individuals with non-bulbar, and that the rise time is reduced if you have bulbar insufficiency, and that you're aiming for a time of 1.5 to 2.5 seconds for the insufflation. You look for a good rise and fall of the chest wall, and that you're getting sufficient volumes. When it comes down to the glottic closure, that you're encouraging or you're instructing the patient to cough. And to coordinate the glottis with the pressure swing. So deep breath in, hold, and then cough. And set the expiratory flow to be 15 to 20 centimetres of water, slightly more negative than the positive pressure you've set. And that you will need a time of 1 to 2 seconds. And what you're looking at in that instance is better cough audibility. Are the secretions coming into the mouth? And are you seeing an improvement in your cough peak flow? And further evaluation of what's happening with the upper airway can happen by any of the factors here. So listening to the air going in and out of the trachea. If not, look at the flow curves that are determined via the MIE device, ultrasound to the upper airway, or looking at transfibral laryngoscopy. All of this to titrate efficacy. I'd really like to spend also a little time talking about chronic suppurative lung disease in neuromuscular patients, as we're seeing this more and more, due to patients living longer and the changes in the natural history. In these patients, peripheral airway clearance techniques, as highlighted here, can be of benefit. The patients that I would target are those with prolonged airway clearance times or a confirmed diagnosis of bronchiectasis. What you should be doing is initiating peripheral airway clearance techniques, but we need to really take into consideration bone density issues. And in those with mild or no issues, we can continue with first-line conventional treatment. If that's ineffective or that further optimization is needed, we can add in chest wall strapping, or if that's ineffective, we can consider adding in high-frequency chest wall oscillation or compression, or if that fails, intrapulmonary percussive ventilation or expiratory flow acceleration devices are an option. However, in the patient with bone density issues, what we need to consider is more oscillations within the within the upper airway rather than externally, so we're not compromising the chest wall, or considering expiratory flow acceleration devices to mobilize the secretions to the central airways to make mechanical insufflation-exsufflation devices more effective. So my final take-home message is that proximal airway clearance techniques improve cough efficacy. Higher MIE settings will increase expiratory flow, but will be less comfortable for patients. ALS patients need an individualised approach to help ensure treatment efficacy, and we should also be looking at treatment efficacy in our other groups of patients, because it's not just the ALS ones, as I showed you with the severe Duchenne muscular dystrophy population, that suffer from airway collapse. In patients who have prolonged proximal airway clearance times, I would really encourage you to investigate for chronic suppurative lung disease and add in the addition of peripheral airway clearance techniques. I'd like to thank you for your attention, and I hope this has helped inform your clinical practice. If you have any questions, please direct them to the BRIAS team, who will be more than happy to pass them on to me, and I can answer any of them for you.